Anemia and iron deficiency HHT is such an important topic. And so I'm very happy to be talking about this, and we should have a good amount of time for questions as well. I'm going to give an overview in the next 20-25 minutes or so, and then we can talk about really hit the questions. I'm sure there will be lots of questions. There always are whenever I speak to HHT patients about this topic. So my disclosures once again. So I think the best way to approach this topic is using the framework of the guidelines. Okay, these are guidelines led by Dr. Faunen, who that are really the framework by which your docs should be managing your HHT the vast majority of the time. Okay, not everything. Not every patient matches exactly what the guidelines recommend, but in general, these are really a good set of guidelines that we can follow, and that is absolutely true for anemia and HHT. Okay, so I'm going to start with the first recommendation for anemia, which is that the expert panel recommends that HHT patients, all adults, regardless of symptoms, and all children with recurrent bleeding symptoms or symptoms of anemia be tested for iron deficiency and anemia. Okay. This is the vast majority of patients with HHT. Okay. Every adult with HHT. All right. Now, the reality is that bleeding and HHT can be highly variable. It is a moving target. Patients who have mild nosebleeds can have severe gastrointestinal bleeding, and vice versa. And it's something that I would say probably gets missed the most, just in terms of the manifestations of HHT that just kind of get missed or under-recognized, under-treated. Anemia is probably one of the ones at the top of that list. More than half of patients with HHT develop a frank anemia at any given time. What is anemia? Okay, anemia is too few red blood cells. All right, what are red blood cells? Red blood cells are the type of cell that makes your blood appear red. All right, and they are critical in transporting oxygen from your lungs to your muscles and organs to give you energy. Okay, so people who are anemic, they have fatigue. They have reduced exercise tolerance. They are not able to get through a full day of work or school. They are not able to do all of the things that they want to do. They get tired early. They don't, they may not have the ability to do social things. When anemia is really severe, people might sleep 12 hours a day. They might really be impacted in their ability to even climb a flight of stairs or two. So there are a lot of different manifestations of anemia and a lot of different levels of severity. And when it's really bad, people go to the doctor and they get found out, right, that they have anemia. The doctor does testing. But when it's not so bad, right, or when they're not anemic and they just have some iron deficiency, it can be missed. It can be swept under the rug. It's really important for people to get screened. And, the frequency of screening really patient dependent. Okay, so there are people who have had known anemia, they've needed iron, they've needed blood. These people are getting multiple tests a year to evaluate their anemia status, their blood status, and their iron status. But what about people who have never had an iron infusion? People that have never had anemia, never known to have anemia. With patients. Generally, most recommendations for general primary care of adults, and for that matter, children, does not include a yearly blood count. Okay. I think for patients with HHT, it should. And I think that the sort of minimum interval for screening with someone who has HHT and bleeding related to their HHT that's reasonable is 1 year. Obviously, it can be more frequent for many patients, but at a minimum, I do 1 year, and I throw on the iron studies on top of that. iron studies in this case are ferritin and what we call serum iron and total iron binding capacity. And those are used to calculate what's called a transferrin saturation. Basically, what that's looking at, transferrin is an iron transport protein. And what that's looking at is in your blood, what percentage of your transferrin protein actually is transporting iron. It's like what percentage of the taxis have people in them, what percentage are empty. And people who are deficient, you know, that percentage is 15%, 10%, 5%. It's very low. It should be above 20 to 25%. Ferritin is an iron storage protein, looks at how much iron is being stored in the body. And really, normal is above 50. People who are sitting at 25 and 30, sort of flirting with deficiency. Many of those patients are frankly deficient. There is no number, by the way. There's no threshold by which we say you are iron deficient or you aren't iron deficient. It just doesn't exist for these tests. We have to look at the numbers, talk to the patient, figure out what symptoms they may or may not have, and make a determination. But most of the time, the vast majority of the time, if somebody's ferritin is above 50 and their transferrin saturation is above 20%, they are not deficient. So we can say that. When deficiency starts is sometimes a moving target. All right. So the second recommendation here is the expert panel recommends iron replacement for treatment of iron deficiency and anemia as follows. Initial therapy with oral iron, intravenous iron replacement for patients in whom oral iron is not affected, not absorbed or not tolerated, or presenting with severe anemia. Okay, what does that mean? So, you know, when you see most doctors who are not hematologists, they will tell you oral iron is great. Let's use oral iron to treat your iron deficiency. And if it doesn't work, we'll send you to get IV iron. We'll send you to the hematologist, get IV iron. I'll send you the infusion suite. We'll get you IV iron. Maybe because we're biased and we just see so many patients who are iron deficient and whom oral iron is not adequate, we really like IV iron. I will give oral iron in patients who have very mild bleeding, who really don't want IV iron, and who can clearly normalize their both anemia and iron deficiency on oral iron alone. There are some people like that, and it's fine for those folks to get oral iron. I often get asked, okay, what kind of oral iron is the best? The kind that makes you the least miserable. So that's the best. Whatever most oral iron causes some gastrointestinal side effects in a lot of people, perhaps most people who take it. Okay, that can be constipation is very, very common. Occasionally, we see the opposite. People can have kind of indigestion. They can have bloating. There are a number of potential side effects that people can have. The first thing that we do is we say, okay, take it less frequently. If you develop these side effects, we'll start patients on one iron pill a day, usually something like ferrous sulfate, ferrous gluconate, or iron polysaccharide. There are lots of different formulations. There's a dozen of them or more out there. What's most important to look at is how much iron is actually in it. So it will give you a milligram total for the pill, and it'll tell you how much elemental iron is in it. It should have at least 35 milligrams of elemental iron. Some of the irons that you get have 10 or 5. I mean, they're not. It's not worth even bothering. So you want to make sure you're taking something with at least 35 milligrams of elemental iron. People ask, well, should we take it twice a day or 3 times a day or whatever? Generally speaking, once a day is optimal for most people. If you take it twice a day, you get slightly more iron absorbed, but not twice as much iron, and you're much more likely to develop side effects. If people take iron pills once a day and they tolerate that okay, and it restores their iron levels to normal, the transferrin saturation and the ferritin numbers I mentioned, and their anemia resolves, then that's great. If people don't tolerate once a day, they can try every other day. Sometimes that will also work. And if that works, great. But if you're treading water, if you have constantly low iron studies, if you have symptoms of iron deficiency and have these borderline studies, I do not hesitate to move on to intravenous iron. And I find that most of my patients are very appreciative of that and of receiving intravenous iron. I already kind of went through a lot of this. One thing that's important to do, and I say prescribe stool softener, in the patient end, you can just go buy stool softener. Docusate sodium is a reasonable stool softener. You can also get, I really try to avoid using laxatives for iron, but Miralax, polyethylene glycol, it's a very gentle laxative. And so Miralax can be okay for some folks who have constipation from oral iron. But generally speaking, if you're having these side effects, most patients with HHT have bleeding for the long term, right? So you have to take this for the long term. It's not like you have to take it for a few months and then you're done. So, I look for something that is long-term likely to be successful. And for most folks, that ends up being intermittent IV iron infusions. You can try, if you don't tolerate one, you can try something else. Most of the time, you still have side effects, but sometimes people don't. So that's something to think about. If you're anemic and you're not improving at least a gram of hemoglobin in 4 to 6 weeks, it's not working. It's not enough. You got to go to IV. IV iron is very safe. It is very effective. I really advise a low threshold to go to IV iron if oral iron is not doing the job in HHT. HHT is chronic bleeding disorder. Sometimes we're able to get that bleeding under really good control and the person doesn't need iron, especially if we use anti-angiogenic therapy. But unless that's happening, chances are the bleeding will be ongoing and the need for iron will be ongoing. And so it's very hard to give somebody too much iron in HHT, I'll put it that way. The IV iron can be dosed in a number of ways. I think it's important not to miss the forest for the trees here. There are formulas that doctors can use to calculate how much iron deficit you have. But again, it's a moving target in HHT because the bleeding continues and is ongoing. So I typically will say administer a gram, 1,000 milligrams empirically, recheck the studies in a few weeks and see what it looks like. You sort of recheck these studies over time and you have a sense for what somebody's ongoing iron needs are. If I need to give them 1,000 milligrams every 4 months, if I need to give them 1,000 milligrams every 6 months, or more frequently or less frequently, or whatever it is. Once somebody is receiving IV iron, they need to be monitored, to figure out that frequency that they need it. And I will repeat the infusion when the patient's ferritin gets to around 50, the transferrin saturation gets to around 20%, because I don't want them to come in 2 months later and be frankly anemic. And I know that they continue to bleed. The question of what IV iron formulation is the best comes up. There's no data on this for HHT. There's also really no data on this just generally for iron deficiency. There are many different formulations, okay? And they all have generic names and brand names. There's iron dextran, there's iron sucrose, there's iron, there's ferric carboxymaltose, there's ferromoxetol, there's ferric derisomaltose, all these different preparations. Those are generic names. And there's brand names like Infed and Venifer and Ferlecit and Ferraheme and monoferric and Injectifer and all of these different drugs. And you may be thinking to yourself, what the heck? Like, do I ask for a certain one of these? Do I, how do I make sure I get the right kind of iron? It matters a lot less what formulation is used. Every different hospital infusion center has their own 1 or 2 iron products on formulary that they'll give. It doesn't matter so much which formulation you get, with one exception. I'll mention that in a moment. What really matters is how much iron you're getting. So just like pills, intravenous iron infusions, you can have a very wide variation. You can get 125 milligrams of Ferlecit as one infusion, or you can get 1,000 milligrams of monoferric as an infusion. One is almost 10 times the amount of iron as the other, and it's just one infusion. All right, so I'm speaking from the US centric perspective. In the US, it's usually the insurance company that decides what iron formulations are okay for a patient to get. Obviously in Canada, it's a different system. But it's important. You may have to come in for more infusions to get that 1,000 milligrams of iron. It's just important to get enough iron, because people will sometimes fixate on, well, I just had an iron infusion. But if that iron infusion is only 200 milligrams or 125 milligrams, it's not enough. You may need 5 or 8 of those infusions in order to get even that 1,000 initial repletion step. All right. Some of the newer products, you can get 500, 750, 1,000 milligrams in one infusion, but those products are more expensive and so may not be as available. This one product called ferric carboxymaltose or Injectafer, I personally advise HHT patients to avoid. I generally advise most people to avoid, to be completely honest, because about 50 to 75% of people who receive that product can develop what's called phosphate wasting. Their kidneys can waste phosphate, which is a very important thing for the body. And this can result in muscle weakness, muscle cramps, pain. It can result in reduced bone density over time. People with HHT, like I said, often receive regular iron infusions. I don't want anybody to be getting that product regularly. One dose, can be okay, but we don't want people to get regular infusions of that one product, which again is called ferric carboxymaltose or Injectafer. The other products are fine to receive, dozens, hundreds of infusions over time with. That's okay. They don't have that kind of side effect. One product called ferromoxetol or Ferraheme renders MRIs unable to be read for about 3 months. Ferraheme is a commonly used product, at least in my neck of the woods, and patients with HHT not infrequently need MRIs for one reason or another. So that's something to just keep in mind. The next recommendation is that the expert panel recommends red cell transfusions in the following settings: hemodynamic instability of shock when somebody's really, really sick, bleeding to death; comorbidities that require hemoglobin target; patients, for example, who have heart disease and have stents in their heart and have had heart bypass surgeries may need a higher, they may not tolerate a hemoglobin as low as anybody else would. Need to increase the hemoglobin acutely, such as prior to surgery or during pregnancy, because we anticipate blood loss in that setting, and inability to maintain an adequate hemoglobin despite frequent iron infusions. All right, so what's the way we do this? So we, in the severity of bleeding, we may initially treat with oral iron. If that's not enough, we then treat with IV iron. IV iron, there's a very, very wide bandwidth for IV iron. Some patients will need IV iron every 2 weeks, and that will maintain their hemoglobin, and they will be fine. They will not need to receive blood transfusions. But occasionally, somebody has a brisk bleed, or their bleeding is so bad that even IV iron is not enough, because their bone marrow, which produces the red blood cells, even though it's getting that iron nourishment in order to make red blood cells, in order to replete the blood that the patient is bleeding out, it can't do it fast enough. The bleeding is just too fast. And so for those patients, you need to start using red blood cell transfusions to maintain a safe hemoglobin or an adequate hemoglobin. So, I think it's important to say, and this sort of dovetails my prior talk, if someone is bleeding so much, right, that they need regular iron infusions, or that the iron infusions are not enough and they need red cell transfusions, that is definitely a time, in my view, that the discussion about what we call disease-modifying therapy or anti-angiogenic therapy should take place. That person has reached beyond the mild to moderate stage. They have reached the severe bleeding stage at that point. Just to give people a sense, in a normal adult female, total body iron stores are about 1,000 to 2,000 milligrams, 1 to 2 grams. In a normal healthy male, adult male, iron stores are about 3,000 to 4,000 milligrams, or 3 to 4 grams. If someone is getting 1,000 milligrams of iron every 1 to 2 months, they are, if that person, let's say that's a woman that's receiving that, they are basically bleeding out their entire body's iron storage every couple months, and it needs to be repleted. That's quite a lot of bleeding. That is not a mild or a moderate amount of bleeding. And so we recognize that we really should start thinking about more advanced therapies in that setting. All right. Recommendation 4, the expert panel recommends considering evaluation for additional causes of anemia in the setting of inadequate response to iron replacement. Okay. The only iron deficiency and bleeding is not the only thing that causes anemia. Far from it. There are many causes of anemia, and HHT doesn't protect you from any of those other causes of anemia. Every kind of anemia that anybody else can get, a patient with HHT can get. And, it's important that if you're given the iron and iron levels are coming up just fine, but the hemoglobin isn't, there's something else wrong. This might be another nutrient that's deficient, might be an inflammatory problem that needs to be addressed. It might be a bone marrow problem that needs to be addressed. It might be a kidney problem that needs to be addressed. Something is wrong. Something else is wrong. And that thing should be investigated. And if your doc is not able to or comfortable investigating that, you should see a hematologist who can help you investigate it. So I will summarize by just saying it is absolutely important that iron deficiency is managed aggressively in HHT. This is a slide that I show to doctors when I give a talk about iron and HHT, because I think it's really important to remember when we talk about treatments, we always talk about risk and benefit and cost. And when somebody is chronically bleeding, the risk of being aggressive with IV iron and with iron replacement generally is extremely low. The benefit is very high. And the likelihood that the person, if you are not aggressive, will show up with anemia a couple months later is very high. And then you're behind the 8 ball. Nobody should be living with anemia if we can help it. If we can help it, you should not be. Living with anemia is a reduced quality of life. Anemia is, I believe, I'm just remembering these numbers off memory, the 5th largest contributor to lost work days and days not worked and reduced productivity in the world. This is a very common problem, and it's extremely common in HHT, and it's readily addressable. And so we should keep the hemoglobin normal and keep the iron studies normal. People who, by the way, I didn't mention this, but people who have iron deficiency without anemia still have symptoms. They can still be fatigued. They can have brain fog. They can have restless legs syndrome, move their legs at night. That wakes them up and prevents them from getting restful sleep. People just have worse sleep generally. They can crave various unusual things, usually crunchy things like ice. That's called pica. There are a lot of different, they can lose their hair, have brittle nails, a lot of different manifestations of iron deficiency that can happen with or without anemia. And there's no reason why people should have to deal with that. So my message to you is get your iron deficiency and your anemia managed. Happy to take questions.
All right, thank you so much for the interesting talk about anemia and how it can affect HHT patients. So let me start off with the first question that we have here. Can iron supplementation negatively interact with any medications, especially in elderly HHT patients?
That's a good question. So, generally speaking, iron plays well with medications. What I tell people to do, and I had it on the slide, but I don't think I mentioned this. I actually advise that you take iron by itself. Take iron by itself. Don't take it with other medications. Don't take it with other food. Take it by itself, because unlike most medicines that absorb better when you take it with food, iron absorbs worse when you take it with food. I recommend that you take iron with you can take it together with vitamin C or a little bit of orange juice or other acidic juice, because the acidity of the juice helps your body to absorb it. So it's better to take iron all by itself. Now, easier said than done, right? People usually take their meds in the morning or in the evening, or both in the morning and the evening, and we're asking you to try to take this at a time that you're not eating breakfast, you're not eating dinner, you're not taking other medications. It can be a little bit of a balancing act. Perfect is the enemy of the good. If you're not able to do that, then take your iron when you can take it. But if you are able to do it, then it is best to try to take it by itself.
Awesome, thank you. So another question we have here. My family doctor always states that serum iron tests are more accurate than ferritin tests. Is serum iron a better measure for HHT patients? What are your thoughts?
So that's sort of half right. So ferritin is a good measure for most patients in terms of total body iron stores. In some people, and including some people with HHT who have underlying inflammation or have inflammatory problems or other diseases that can impact the ferritin, ferritin is not as accurate. Serum iron is only half of the story. Serum iron is it's what we call labile. It can go up and down. If you eat if you stop by McDonald's on your way to clinic and you have a meal and then you had your blood drawn and you measure your serum iron 1 hour later, that serum iron is going to look good. You just had a hamburger. You just absorbed a bunch of iron. So, or if you take your iron pills and then you go get your blood drawn, ferritin is going to not fall victim to that. So you need both ferritin and what's called transferrin saturation. So when I say serum iron is only half the story, the serum iron is one part of that equation. It's the numerator, and then it's what's called the total iron binding capacity is the denominator. And that's a calculation that the doctor needs to make. And it gives you a percentage from 0 to 100. And that percentage should be above 20%. And if that percentage is below 20%, that may be what your doctor is alluding to. Not just the serum iron, but the transferrin saturation, which is again a measure of how much iron is really floating around in your blood at that moment. That can be accurate when ferritin is not in some people who have other problems that can raise the ferritin, or inflammation that can make the ferritin look high, but the patient is still iron deficient. Now, I just got through saying that there's issues with ferritin, there's issues with transferrin saturation, right? So if you ideally want to get your iron labs when you're fasting, or if you're not fasting, at least a few hours from the last time you've eaten a meal. Because again, the transferrin saturation can come back normal when it's really low. If somebody has a meal an hour or two, or they take their iron pills an hour or two, up to 4 hours before they have the test. In fact, we actually, it's called an iron challenge test. When we wonder if a patient is able to absorb iron, we give them an iron pill, and then we measure their iron, 2 to 4 hours after that pill has been given. So, you don't want, and your doc may not ask you when you took your iron, probably not going to ask you that, not going to ask you when you had your last meal. Try to make sure that you're not taking your iron right before you have your iron labs drawn that day.
Great, thank you.
Yep.
So another question we have here. You mentioned that the frequency of blood tests are kind of on an individual basis. Do you have a rough suggestion as to how often an average HHT patient should be getting their iron studies done, and what factors might affect how often they should get tested?
It's a good question. Honestly, HHT is just too heterogeneous. It's just everybody is so different. I mean, on one hand, I have patients that have such mild bleeding that they've never ever needed an IV iron infusion, really almost never even needed oral iron. And then on the other hand, you have people who are dependent on IV iron or transfusions by the time they're in their 30s or 40s. So it's really, really variable. I would say that if you have never needed IV iron and you're doing fine either on no iron or oral iron, maybe once to twice a year is reasonable. If you've needed IV iron and that IV iron need wasn't just at the time you were diagnosed, and you've been stable with your intermittent IV iron infusions for maybe a year or 2 years, you could probably get your iron studies checked every 3 months or so. Every 3 to 4 months would be a reasonable sort of average number. If you're getting regular IV iron infusions, then you need to get your studies checked regularly. What depends on what the interval of your IV iron is, but if you're getting regular infusions, you're going to get those studies checked regularly.
All right, so another question here is, I have taken iron supplements for a while and have very minimally increased my ferritin. Yep. Is there evidence to suggest that HHT patients have issues absorbing iron?
That's a great question. So actually, it's the opposite. HHT patients, the body is really primed to absorb as much iron as possible. Somebody is chronically iron deficient. When you're iron deficient, your body will upregulate the amount of iron you're absorbing. Now, it's a little bit, some people are sometimes really surprised by how little iron they actually absorb in the iron pills they're taking. Your iron pill may have, let's say it has 65 milligrams of elemental iron in it. Typical ferrous sulfate has 65 milligrams per pill. Your body, under normal circumstances, when you are not iron deficient, may absorb 2 milligrams or 3 milligrams of that elemental iron. The rest comes out in your stool. That's why your stool is black when you're on oral iron, okay? Because you're not absorbing the vast majority of it. Patients with HHT might absorb 10 milligrams, which is a lot more. It's like 3 or 4 times more than a patient without HHT, somebody who's iron deficient, someone who has, in particular, iron deficiency anemia. The body is saying, I need that iron. I'm going to try to absorb as much as I can. But the body is just not able to absorb that much iron from the gut. So we can give tons and tons of iron in by mouth. Most of it will, the vast majority of it will come out in the stool. Most of it, a lot of that will lead to gastrointestinal side effects, which is unpleasant. So, is it possible for a patient with HHT to have an absorption problem? Sure, absolutely. Just like anybody can develop an absorption problem, people with HHT can develop it. But the default, the baseline, is that you're actually primed to absorb that iron more so than the average individual. And if you're not normalizing your numbers, you probably need IV iron.
I think one more question here. If in anemia, your body has difficulty getting enough oxygen because of the lack of iron to transport it, could this cause an increase in angiogenesis and thus make HHT a little bit worse, and therefore a really important factor in treating and keeping HHT properly managed?
That's a really good question. It's a question that we don't really know the answer to. But when the body is in a chronic anemic state, there are physiologic changes that take place that try to accommodate that state, try to essentially make up for the fact that the oxygen carrying capacity of the blood is not what it should be. We don't know whether that will result in somebody developing more AVMs in their lungs or liver, for example, or result in them developing worsening bleeding because of the propensity for blood vessel development. There are some differences in the pathways that are involved in these things, but I think sort of irrespective of that, and again, you can tell I'm a hematologist, nobody should live with anemia, okay? Anemia is bad for lots of reasons, not just the quality of life stuff, not just the lost productivity. And by the way, there's a very, I think, a sort of odious and insidious element of sexism to this too, just to say, because, who is most likely to be anemic outside of HHT, right? It's women, it's young menstruating women. And, it's sort of viewed as like, oh, kind of normal. It's not normal for anybody to be anemic, including a menstruating woman. And it's sort of in families, it's sort of normalized, oh, my mom had heavy periods, I have heavy periods, every woman in my family has heavy periods, we're all anemic. No, should not be anemic. That is a failure of medical care. That needs to be adequately addressed. 20% of the world's population, the majority of whom are women, have iron deficiency anemia at any given time. Iron deficiency, in addition to causing all these quality of life issues I mentioned and all these, sort of unwanted side effects, it increases the risk for blood clots, which we really, really don't want in HHT. And so I think it's really important to ensure that your iron levels are being properly managed. You're not walking around chronically anemic, chronically iron deficient.
Great. So I think we have one last question here. Can iron cytotoxicity ever be a problem for HHT patients?
So iron, this is an excellent question. So as a hematologist, most of my patients, because I'm an HHT guy, most of my patients to come into the door need more iron, but the ones that don't need more iron often have too much iron. Okay, so I have patients on the other end of the spectrum. People have diseases like thalassemia and sickle cell disease and pyruvate kinase deficiency. These are disorders in which the blood breaks up. They're anemic, but it's not because of lack of iron. It's because of other problems. And the body actually is absorbing too much iron and storing too much iron. And that actually is very bad for their liver and their heart and their endocrine organs, their pituitary and their pancreas, and it can cause all sorts of problems because too much iron causes damage to cells. It's a bad thing. We don't want that. Now, it is very, as one can imagine, it is very, in a patient with HHT, it would be very, very difficult to give a patient with HHT who has ongoing bleeding so much iron that they actually develop an iron overload state and have problems related to this. Is it impossible? No, it's not impossible. But I mean, it's something that if your numbers are being checked and followed regularly, it really should be an occurrence that would be extraordinarily rare. So I think that it's not something that you need to be effectively worried about, and it's something that is really more a concern for people who have other blood disorders that result in too much iron.